Um, Today we have an absolutely star-studded cast of attendings and
Kevin, no.
He was sounding so
Oh, no.
good.
Appeared. It was such a nice intro.
It was going so well.
So I will continue on. Hi, everyone. My name is Tori, and I'm the Strategy Vice President for National APAMSA. As Kevin was saying, we have a star-studded cast of residents and attendings for family medicine. And with that being said, I will go ahead and start the slides, and we can start the session. So thank you all for being here. Okay, welcome everyone to the 2024 APAMSA Family Medicine Bootcamp. We are so excited to have you here today. This is the 6th and last session, and it's really exciting because this is the first year that we are having family medicine. Please feel free and welcome to participate in the chat box. If a presenting resident speaks, the remaining 3 non-speaking presenters will answer your questions in the chat box. And if you are an audience member and want to answer a question from your peer, please announce your name, school, and year of training. Additionally, we will not have an intermission today, but please feel free to have a bio break and the speakers will continue speaking. We also value your input and welcome your feedback through this QR code. All of the feedback, your thanks, acknowledgements, and suggestions will be sent to our speakers. And we also welcome feedback for the logistics of these bootcamp series, and so that National APAMSA can continue improving this in years to come. And without further ado, it's time to introduce our wonderful speakers. First off, we have Dr. Justin Chin.
Hi, everyone. I'm Justin. I'm a family medicine attending and faculty over in Richmond, California at Lifelong Medical Care. Work passions include preventative medicine and undergrad and grad med ed. And non-work passions include traveling and going to conferences. In the picture there is all the loot I tend to loot at conferences and take all the things.
And next we have Dr. Ryan Fang.
Hey everyone, I'm Ryan. I'm a third year resident at Swedish Cherry Hill. And sorry, I'm just kind of like starstruck by Justin's loot picture. But anyways, I'm interested in HIV, LGBTQ health. I'm actually doing palliative fellowship starting in July. And as you can tell by my setup, I also enjoy video games and, generally having a good time. So thanks for having me.
And next we have Dr. Sunmi Wentzel.
Hey, I'm Sunmi. I'm from, it's kind of complicated, but I mostly grew up in South Korea. I went to med school at Ohio State, where I also got my MPH. And now I'm an intern at Cherry Hill Family Medicine with Ryan and Leena. Some of my work passions include gender care, repro health, OB addiction, adolescent medicine, procedures. And then when I'm not at work, I love taking long walks and playing with my cats. I have 4 cats. And sorry, my partner's in the background, and spending time with my partner and reading and writing poetry.
And last but certainly not least, we have Dr. Leena Yin.
Hi, everyone. I'm also at Swedish Cherry Hill with Ryan and Sunmi. I graduated from UCSF. I'm a second year. I am passionate about and happy health, as well as adolescent health and health justice, sexual health, and I love boba.
Without further ado, we will get started with Dr. Leena Yin.
Yeah, this is just a quick intro to set up our expectations for the session, right? And just so everybody is prepared, we are going to be talking at 2 times speed because you are medical students, so you should be used to that speed. And we have a lot of topics to cover because family medicine is such a wide spectrum field, right? We cover everything from birth to death, including prenatal, OB, reproductive sexual health, inpatient medicine procedures, and we are also at the forefront of so many different fields that involve overlapping what people would consider usually like specialties or subspecialties. So that's like palliative care, geriatrics, pain, immigrant refugee care, rural care, etc. We're obviously not going to be talking about all of that today. Next slide. We are going to be covering some like basic screening, preventative care, office care for chronic medical conditions, pediatrics, prenatal, reproductive and sexual health, gender affirming care, HIV, addiction medicine, some MSK, and some geriatrics with a heavy focus on clinic care, outpatient care, since y'all will presumably have gotten a lot of inpatient stuff from the internal medicine bootcamp. And really, really important, do not memorize everything we're about to tell you, right? Medicine is all about saving your references and using them at the appropriate time. So we're going to be giving you a lot of tables, links, things that you can definitely save. You'll get access to the slides if you fill out the feedback form. And you can also feel free to screenshot things, of course. Okay, next slide. And this is just a really brief intro from Dr. Chin about how to succeed as an intern as you prepare to start your FM residency.
Hey everyone, so as an attending, here are some of the best practices from which just seeing residents from intern to third year, some things that can work well. So one, click next please, is chart preparation, taking a look at chief complaint, chronic conditions, and healthcare maintenance, really using chart prep as a way to, oh, too fast, to establish care. And every panel is created differently in a residency. And a lot of your patients have been used to seeing residents and kind of that revolving door. So really know your patients by showing that you know their history. When they come in with a chief complaint, have a differential for what brings them in as their sole problem, using as a guide to ensure what's most important to the patient is taken care of. At the beginning of residency, being expansive, not anchoring, and showing what you thought is most common and what is most dangerous versus zebras. As you progress, use that to streamline visits as you continue to see the patients over the years. For chronic conditions, making sure that you know what has been done, who are the specialists, what are the medications and therapies, and most importantly, what are we doing to advance and continue care? So this can be what their course is, how do you add things, what are the guidelines versus what are the abilities of the patients are able to do. For healthcare maintenance, really taking a look at age-appropriate screenings and really using that as a way to safely take a look at different things for patients. Go ahead and hit next, please. So next thing is really for every rotation, set up SMART goals, which are specific, measurable, achievable, relevant, and timely goals that are going to be great for both you and your patients. Use it as a way if you have things that you want to improve in your clinic and your rotation for yourself or for your patients. Next, please. Going into that, set up SMART phrases. So those are specific for the EPIC EMR, but a lot of other EMRs have similar things in which that's a way of becoming more efficient. If you're writing something more than 3 times over the year, make a SMART phrase for it, because otherwise you're just going to keep on repeating it over and over again. Next, please. SOAP is a good way to hit next again, please. SOAP is a good way to format your presentations, and then APSO is actually a good way to do for notes to reduce charting fatigue and see how you can change residency workflows to support that. Definitely talk with your residency to see if they support different ways of formatting your presentation and how to write your notes. Next, please. Speaking of workflows, it's important to understand how your clinic works and how you're working with your MA, your front desk, referral, etc. That's really a core to team-based care, and that way you can help folks practice to their highest scope of care. And then finally, next please, looking at systems-based care and understanding what resources are available, how to access that, and how to integrate care to other folks. Emails are a lot in residency. So sometimes you can just make a SMART phrase for different updates, and that way you can just have a SMART phrase that pulls up an update in the event of things changing in prenatal, pediatric, etc. care. Next. And there's a little picture of that. Next, please. So from there, we're going into, oh, too fast. going back again, please. Looking at the USP-STF guidelines, this is the bread and butter of family medicine in terms of preventative medicine. It basically presents the baseline of care for all of family medicine for adults and pediatrics. On my slides, you'll see a QR code. The QR code will take you to places that are good to keep in your resource bank. So for this one, it's taking a look at an app that actually pulls up the USP-STF guidelines. And that way you can then use it to plug in your different patient demographics if your EMR does not already have it. Next, please. So the USP-STF guidelines are split up through A through I recommendations. There's no E and F because who knows why. But A and B are usually the gold standard of things that we do. C is kind of all over the place. D is don't do it because you're going to mess something up. And I is actually where the majority of statements tend to lie in terms of we don't really know if it's helpful medically in terms of the studies, but a lot of the times you'll actually see things that you do in your clinic that are actually I recommendations. Again, these present the baseline of a lot of the things that we do in clinic, but depending on whichever organization also can give more concrete or more specific recommendations. So big examples include, like, for example, ACOG, which is the American College of Obstetrics, or AAP, the American Academy of Pediatrics. They can give more specific recommendations, and that sometimes is actually what your clinics may be using. So definitely check in to see kind of what the expectations are in your residency, especially when you're precepting, to figure out which ones will they be using. For most parts, for STEP and level 3 and ABFM and ABOFP, which are your STEP and level 3 boards, and then your board studying, you'll typically be given USP-STF guidelines rather than those of the specific organizations. Next, please. So here are all the A and B recommendations. I recommend that everyone just memorize them right now. I'm actually just kidding. There's 55 of them. So no, do not recognize all of them. In most parts, you'll actually see them as health maintenance topics that need to be completed. And they're on the right-hand side here of what they would look like in EPIC. So it's only as good as you remember to update them. So if you are ordering things like mammograms or colonoscopies, and you use an external system that then integrates in, if you don't remember to complete it, it will always show that it has never been done. So it's a way to kind of keep things in track. Other ways include using smart lists and things of that nature. Next, please. Next, we have the C recommendations. So unlike the A and B recommendations, these are kind of all over the place in terms of where it is. There's actually another 8 more, but these are the ones that are most common that you would see that are C recommendations that your attendings or your preceptors may, depending on when they're training, say that, oh, have you thought about this? Or what do you think of that? Each have their own risks and benefits, and each have their own different organization that kind of adds or decreases to it. Next. So for example, the aspirin and primary ASC VD prevention, the AHA and ACC have their own recommendations. The QR code there for multimodal fall intervention geriatrics, the Geriatric Society has their own. And then finally, for PSA screening, the AUA, or American Urology Association, has, again, their own recommendations regarding that. So depending on your attending, you may want to mention that you are using a more specialty serviced recommendation in order to do that. Next, please. And here is just another way of taking a look at the A and B recommendations. So there's so many different ways of how you can keep this track. For a lot of the times now with our EMR systems, they will keep that in track for you. So just something to keep in mind. A lot of folks have different ways of how they like to keep that. Next. From there, we go into the ASCCP recommendations. Next. So for the ASCCP, it is the American Society for Colposcopy and Cervical Pathology, and this is the big organization that guides Pap smear recommendations. On the left there is the QR code for the ASCCP app. You can either download the app, which is, I believe, $10. It's just a pretty solid price for it, or you can actually just go online and plug it in that way. Use whichever one is more convenient to you and see which your workflow is. If you do buy it, most residencies will reimburse you if they are not being cheapskates for you to buy the app. From there, that is what the app will look like. Oh, yeah, there you go. And basically, it's depending on your different scenarios, you plug them in. Depending on the number of pap smears you've done, you plug that in, and bing, bang, boom, you'll have a recommendation, and it'll figure for a nice algorithm of what to do. Next, please. This was a little bonus thing because you can't really talk about recommendations unless you talk about, next, please, shots. So shots, everybody, let's get shots. So if you actually took a look, and those that are eagle-eyed for the healthcare maintenance, you actually saw a lot of vaccine recommendations on there. So this is because the CDC and the ACIP, Advisory Committee on Immunization Processes, puts out recommendations for age-appropriate vaccines. And again, these vaccines serve as the foundation for preventative medicine and are critical when you take a look at new immigrant health because different folks coming from different countries can have different vaccination schedules, different names of vaccines. A lot of them are handwritten. This is an example of a couple of different vaccine records I've received in clinic, and trying to figure out what they are or even deciphering the numbers is a challenge. Next, please. So over here, we have the pediatric vaccine schedule, which include the babies and also the adolescents. There's a QR code there that will bring you to this table. It is good to have, especially as you start up your pediatric rotations. Next, please. And then from there, we have the adult vaccine schedule there. From here, we are now hitting into the big three of the bread and butter for family medicine. As a big picture, there are so many different conditions that you will see in family medicine, but three that we chose to cover today is hypertension, hyperlipidemia, and diabetes. For things such as heart failure, asthma exacerbations, all those things, check out the internal medicine bootcamp. They probably got that covered. Next, please. So defining hypertension, that is a great question that you need to take a look. Are you going to define them from the JNC8 guidelines or the ACC-AHA guidelines? The ACC-AHA is the newer set of guidelines that kind of stratify them slightly more. So depending, again, on your attending or your preceptor, you may want to risk stratify your patients and say that I am using the JNC8 or the ACC-AHA guidelines, so that way they understand what you are using. Of note, there is also guidelines for pediatric hypertension. However, that is a little bit more complicated. Check out the link there to calculate things for pediatric hypertension, because they use things like height and weight to also give you some guidelines there. Next, please. So for treating hypertension, this is the algorithm you have for JNC8. Do not memorize, pull it up each time until you become comfortable with it. There is the QR code that brings you to the AAFP article. For most parts, I tend to use the AAFP interpretation of any of these guidelines because ultimately we are family medicine doctors. So therefore, we will use the family medicine org interpretations. Next, from there, we have treating hypertension through the AHA-ACC. Something to keep in mind for both the JNC8 and the AHA-ACC is the AHA-ACC don't really give specific recommendations of the pharmacotherapy versus the JNC8 does. For the JNC8, something to keep in mind is a little bit of some questionable natures there of race-based medicine in terms of they do stratify some of the medications based on African-American or Black race, to which some of the newer studies now are really putting into question whether or not that actually holds true. So just something to keep in mind depending on the patient populations you serve. Next, we're rolling into hyperlipidemia. I'm hoping I'm keeping everyone engaged at my 2x speed. For hyperlipidemia, next please, we have to, oh wow, very fast, define what it is. So taking a look at most part with cholesterol, from there going into your ASCVD risk calculator, which takes a look at your risk of cardiovascular disease. And from there, using this fantastic super small chart that you can't really see on the screen here, but once you download the PowerPoint, you can zoom in, taking a look at whether or not you would recommend treatment or not. The next slide there. With treating hyperlipidemia, you can then risk stratify folks based on their ASCVD score and along with the different treatment options. Long story short, statin is your first line unless contraindicated. And depending on how well resourced your program is and patient population and things like that, there are newer medications that are not even on here. Things, of course, like the PCSK9 inhibitors and some of the other newer medications. Unfortunately, those are usually upwards of $30,000 to $40,000 for treatment for the year. So statins are the way to go. Next, please. Rolling into the last of the big three is diabetes. Diabetes could probably do a 1-hour lecture in and of itself. I tend to enjoy talking about diabetes because that is an area of interest for me. But next slide. We take a look at how we define diabetes. Diabetes in and of itself has lots of different criteria, and also the type 1, type 2, type 1.5, everything else in between. We have gestational diabetes. Here we're going to talk really quickly on type 2 diabetes. Over there we have the pre-diabetes and diabetes diagnostic criteria along with their definitions. And then a lot of the times when patients are coming into you, they're really going over the symptoms of diabetes. And generally, diabetes is pretty silent until it gets to the uncontrolled level. We usually get the polyuria, polydipsia, sometimes even the autonomic and peripheral neuropathy symptoms are the first that show. Next slide, please. And I put this up there, I put this up there because for men, the most common symptom for diabetes that they tend to say is they want Viagra in the clinic, because that's the only way that 50-year-old men will come to clinic, is all of a sudden things aren't working. And then you test them and then they're diabetic, and that's why they can't point and shoot. Next slide, please. So this is the giant chart of diabetes medications. Long story short, metformin, first line. After that, add a GLP-1 or SGLT2. There are new guidelines in the works that will be saying potentially that we will be recommending SGLT2 and GLP-1s before metformin. But until that is the case, metformin is first line. Next, please. So yes, before that, the biggest thing in that little red box that showed up there, comprehensive lifestyle management. That is always going to be the first line that is asked on all exam type questions is what do you do first? Diet and lifestyle modifications. Easy to say, very hard to do. On the right side here, by the way, I also put in a quick guide of all the different medications and also the brand names. For a lot of the times, the patients will be like, I take the injection or I take the little blue pill, all of these different things. So in that case, this is just a way to keep in mind of all the different generics and brand names and what class they are. Next, please. As a little bonus slide, insulin, what to do. There's a QR code for what to do with insulin titration. If you are confused about insulin, there's a chart there of rapid, short-acting, intermediate, long-acting, and kind of what their different brand names are. When in doubt, throw on a brand name. In terms of Lantus, long-acting, it's the easy one to deal with. From the QR code there, that will help you measure how much to start them on. And then if you had to do a postprandial insulin, this is how you could titrate based on the bottom. A quick titration is up top, in which you take a look at their fasting blood glucose and increase and decrease insulin based on there. Very confusing. I would definitely recommend reading the AFP article to kind of give yourself a primer on how to start patients on insulin. Next, please. Lastly, for all your diabetic patients, this is a pet project of mine, is really taking a look at diabetes and how it affects every other aspect of their health. So taking a look at the healthcare maintenance that comes with diabetes, and that includes the diabetic eye exam, the foot exam, and then appropriate vaccines by the CDC and ADA. Because we have seen throughout the years, diabetes does increase the risk of infection. And from there, I gave it over to Leena to go into pediatrics.
Yay. Okay, so I definitely started my intern year not really knowing much about pediatric outpatient care. I feel like I saw a bunch of like well child checks and I like did like a rotation, but somehow left like not really having a solid foundation despite taking my shelf. So here's how I felt on the left, and here is now how I feel on the right. Next slide. So obviously, just like Justin, there is a giant table that you can memorize. It's literally every single recommendation for every single age from 0 to 18 from the AAP. And you could memorize this, or you can just sort of have a general framework for a well child check, which is the annual like exam that you do for kids when they come in once a year. Exactly. So this is my framework, right? And what works differently for everyone. What works for everyone may be different, but this is my framework. And I think it just helps to have this like broad idea in mind of like, what are you doing? Like go into the room, right? You have a 3-year-old, 4-year-old, 6-year-old, 7-year-old, 8-year-old, they're all the same. So the first thing you do, just like a regular visit, is pre-chart, get to know the patient, right? And particularly if they've been seen in your clinic before, you want to understand, do they have any recent like changes to their health, in addition to the past medical history you already know. And then you're going to get a bunch of numbers, just like for adults. Of course, some of the numbers are different, right? Because you're going to be comparing their height and weight to their growth curve, which will be different depending on when they were born, their age. And then you'll get a head circumference for folks whose sutures and fontanelles haven't closed yet. So that's anybody under the age of 18 months. And then you might get blood pressures depending on their age, and you might get a vision and hearing screening, again, depending on their age. So those are numbers that you're going to see that are different from adults. And you might also get a pre-visit questionnaire. Some clinics have different flows for collecting this information. Sometimes you might be the one asking the parent, hey, is your child crawling? Are they like grasping things, et cetera, et cetera. But sometimes you might be able to have them fill out like a pre-visit survey and be able to just review that and know if kids are meeting their milestones. And then you just go in the room and you take the history, just like a normal visit, right? You ask if they have any concerns, any updates to their health. And then you take a pediatric review of systems, which unlike for adults is not like headaches, vision changes, chest pain, et cetera. It's about eating, pooping, peeing, sleeping. Are their teeth good? Where are they living? What kind of exposures do they have? Do they go to school or daycare? And then for teenagers, there's the SHADES assessment, which I will talk about in a little bit. And then there is like developmental screening from like an autism spectrum disorder perspective. And you do a head-to-toe exam. There are special maneuvers, right, depending on the age. Again, so red reflex. Fun fact, the AAP actually recommends getting the red reflex for every single well child visit until the age of 18, which is hilarious to me because I don't think any of us do that. But definitely something to remember that you still do, even if even after like the initial newborn check, right? Like you're still doing it maybe until like 4 to 5 years old, even before the kid can maybe tell you that they are having vision difficulties. Remember when the fontanelles close, remember to screen for scoliosis around the right, like pre-pubertal, like peripubertal age, because that's when we can really intervene to make a difference in someone's spine development. Tanner staging is always plus minus for me. I might do it if some parent has like a concern about abnormal development, but otherwise I like don't always examine someone's genitals. I feel like that's a little bit invasive and like folks don't need that. And then blood tests as relevant. Lead screening is covered by Medicaid at 12 months and 24 months for every kid. If they have private pay, you might then be weighing sort of like, do they have any risk factors? Because that's when their insurance would cover the lead screening, anemia screening, and then anticipatory guidance, which I did not understand. I think really like I was just like picked random things when I was a med student to talk about. Nowadays, I literally just print out the Bright Futures handouts. Thanks, Ryan, for making sure we have those in clinic in every language. And I just review them line by line with the parent. And that way I never forget things. And the parent has like a guide that they can take home in case they forget. And then, of course, Justin already talked about vaccines. Something that will make parents love you is if you prescribe the right dosage of Tylenol for their kid, for their kid's weight, because parents always feel really anxious about that. And it like gives them a pre-warning that if a kid gets vaccinated, they probably will have a post-vaccine reaction, which can include a fever. So that is just something to keep in mind. Next slide. Yeah, this is just vaccine dosing. This is just Tylenol dosing for parents. Next slide. Okay, and then there's like special things that come up during the well-child check. So sports physicals, the AAP actually has a guideline for sports physicals. That link is included. You can click on it there once you get the slides, or you can Google like AAP sports physicals. But every school will have a different form too that you're gonna have to fill out. Usually, what it means is the school, if the kid collapses of like sudden cardiac death, like on the soccer field, the school wants to know that they won't be liable because they already sent the kid to you to be screened, right? So that's the things that you're going to be thinking about when you're asking and examining them. And then for teenagers, now we're moving towards the SHADES assessment, which is a strengths first assessment, includes all the things in the old HEADS assessment, but with a focus on the strengths that the teenager can really bring to their lives, because we know they have a lot of risks, but they also have a lot of strengths, and we want to elevate that. And just one last piece about confidential visits for teenagers. Of course, you're always trying to do it starting at age 13, right? You're going to ask the parent to step out of the room, with the caveat that folks, that you are a mandated reporter, and you're going to have to report things if you are worried that the teenager or somebody in their life is at risk in terms of their safety. However, it is also really important to understand sort of the workflow for your clinic and your state, because different states have different guidelines in terms of like what can actually be confidential and what is not. And depending on, for example, what the teen wants for their care, like if they want like a pregnancy test or something, does your clinic actually have a way to keep that order confidential from the teen's guardians, right? Because like it might still show up in their insurance like bill, right? It might still show up on their My Chart, which is something the parent can't access. So making sure not to promise anything that you can't keep. Okay, next slide. All right, and then babies, what are they? So I just wanted to highlight a couple of things about the newborn exam, which is what you do, when the baby is born, and what you do at that initial visit when that baby gets discharged and comes to you for the first day, right? So the big three categories you're looking for are signs of trauma from the birth, right? So you want to know about the caput, you want to know if there's bleeding or cephalohematoma, you want to know if there's crepitus in the clavicle, right? If they accidentally broke the clavicle and the baby's way out. And then you want to look for hip dysplasia, which is a congenital thing, which is like in the second category. So like sort of congenital abnormalities, birth defects. So that includes like cleft palate, which is why you check for the palate, ear pits, which is something I'll talk about in a second. And then like signs of spina bifida, which is why you look for a sacral dimple. Next button. So here's an ear pit. It's more common in Asian babies, apparently. I didn't know that, but it's associated with genetic disorders and hearing defects. And so if you see one of these, you want to send them to audiology. Next one. And then here's a tongue tie. So we want to also know that the tongue is freely mobile. If it is not necessarily a problem, but it might impact lactation and breastfeeding. And so if that is the case, then you can actually snip it in clinic. That's a family medicine procedure that you can do. Next one. This is just some maneuvers of the hips. Keep going. These are just really pushing on the hip. Okay, great. And this is a simple dimple. This is an example of a dimple where we're not worried about the spina bifida. And the characteristics of a simple dimple is that it's like close to the anus. You can see the base. You're not worried that it's going deeper and something else is going to come out of that space. And that the baby has no other abnormalities on exam. And I highly recommend the Stanford Newborn Exam website. They have like pictures of like all of these, like both normal and abnormal findings in the newborn. It's a really, really great teaching tool and reference. Next slide. Okay. A brief thing on circumcision. It is, whether or not someone should do it is still purely elective, right? It's a cultural thing. Americans do it more than anywhere else in the world. And there's some evidence for health benefits, but really not enough that it's something that we're recommending, particularly with like sort of the issue of like, is this a consensual procedure on the part of the person who is getting modified? But can you do them as family medicine? Absolutely. And it is a simple clinic procedure if you've ruled out the contraindications below. And here's just sort of a demonstration. You do sort of a local block, you dissect the tissue away from the glands, and then you like put in a clamp for hemostasis and you cut. So it's actually quite simple. And again, something that you can do and learn to like be competent in as FM if you are interested. Next slide. Okay. And then if I have time, I was going to go through a couple of simple pediatric complaints. So I Googled common pediatric complaints. And these are the ones that I came up with, which I think sort of jives with my personal experience as well, both in the office and the pediatric ED. So belly pain, respiratory concerns, fever, rash, and then like growth or developmental abnormalities. Next slide. So starting with belly pain, somebody comes in with belly pain, right? Like, what are you thinking about for a kid? Is it going to be different from what you're thinking about from an adult? adult, some things will be the same, some things will be different. So next click. So separated on like the sort of generally on the left is like things that are like less acute, like less problematic, and then on the right, things that are like more acute, more problematic, need to be treated more urgently, right? So like viral gastroenteritis, like probably the most common thing that we see in terms of acute abdominal pain. Obviously, you can tell if someone's like sick, they might have other sick symptoms, nausea, vomiting. But this one is really just about like looking at how dehydrated the child is, like whether they're able to keep up with their fluid needs, and if you need to send them to the ED if you're seeing them in the office for like IV fluids, essentially. Constipation is a really big thing in kids, and it can even happen in babies. And I also have little notes in this table for your reference in terms of like there are things that we use in adults commonly that sometimes we don't remember if they're safe in children or not. So Zofran is safe for kids over 6 months old. Miralax and Senna are also, but for infants, you might want to consider using prune juice or pear juice instead of one of those medications. GERD is also common in pediatrics and may be more associated with spit up or chronic cough. And fun fact, PPIs and H2 blockers like famotidine and meprazole are actually safe in infants. So something you can offer, though at that point, you're probably referring them to GI. Obviously, you never want to miss an acute presentation of appendicitis and intussusception, or DKA is actually another like overlooked but very common cause of surprisingly common cause of abdominal pain in children, and would be associated with other things like the polys, as well as weight loss, possible UTIs, lethargy. Next slide. I also wanted to, sorry, next slide. I also wanted to make a small note on dietary intolerances, since that is something very common in pediatrics and also can be a cause of abdominal pain, right? So when it comes to allergies, food allergies, you have like IgE-mediated food allergies. Milk protein allergy is a subset of IgE-mediated allergies, and the milk protein allergy actually shows up pretty early in life and can self-resolve, so parents will often be very freaked out about it, but it's often safe to reintroduce milk protein in like 1 year of life or 1.5 years of life. And this is something that you might see in babies, like bloody poop, like poor weight gain, fussiness. And then in terms of, sorry, that arrow should be less than 1 year. And then lactose intolerance is not an allergy, right? They're different. And that is just like white people for some reason decided they wanted to keep drinking milk. And the rest of us were like, no, this is stupid. And our bodies don't tolerate it. And then celiac disease is non-IgE mediated also, and it's an inflammatory action. The reaction to the gluten damages, right, your like intestinal lining. And that is like something you see in older folks usually, but it can be associated with type 1 diabetes and hypothyroidism. Fun fact, for celiac disease, you can do serum testing, but ultimately children will need a confirmation with AGD biopsy. So you will be sending them to GI if that's something that you're suspecting. And then for food allergies, you're frequently going to get the question from parents like, oh, should I go to an allergist? Like, what should I do? And yeah, you can send them to an allergist. However, the testing for allergies ultimately is really about seeing how people respond to the food, which parents are always really freaked out by. So there's no really like that. You can do serum testing, you can do skin prick testing, but ultimately like knowing whether someone is truly intolerant is just seeing how they respond to the food. And you may be able to slowly reintroduce and build tolerance again. And then just a reminder that EpiPens come in 2 different doses depending on weight. So there's 1 dose for the kids who are smaller and one dose for the kids who are bigger. And parents will be bringing you those like forms for school administration. So you should know what the dosages are. Okay, next slide. Respiratory distress, respiratory season is very, very long. It feels very long for kids because it basically starts when school starts in the fall and then doesn't end until like late spring, I think. And so it's really important to differentiate your diagnoses of like asthma, bronchiolitis, croup, pneumonia, right? You'll never want to miss a pneumonia and know if there's a bacterial infection, particularly that needs to be treated with antibiotics, and then whooping cough, which unfortunately is highly contagious. And even for like vaccinated folks can be contagious if it's been 5 years out from their booster. And of course, there are kids who are too young to have gotten the D-type vaccine, right? So you always want to keep that in mind. Here are some like differentiating symptoms, and the care for them is different. I'm not going to talk about everything, but this is something that just the more that you see of it, the more you'll hear a kid and be like, oh, that's croup, or like, oh, that's asthma. And then going back a little bit, viral URI is sort of our default diagnosis if the kid does not seem like the URI hasn't resulted in any of these complications, and the kid may overall be like better and well appearing. Just remember that when we say URI, because I feel like people said this all the time, and I was like, this doesn't jive with any of the anatomy I'm learning in medical school. It's a viral infection of the nose, mouth, throat, or larynx, right? And so like you're thinking about croup, you're thinking about lower laryngotracheitis. For pneumonia, you're thinking about lung parenchyma. And that is what correlates with the anatomy that you learn in medical school. Okay, next slide. Fevers. Parents will bring their kids in for fevers all the time. One of the number one things I hear from parents is the fever was so high, I was scared that it was going to burn the kid's brain, right? So it's important to provide reassurance in these circumstances. If the fever is responding to Tylenol and ibuprofen, it's probably not something to worry about. Of course, you know that if it's longer than 7 days, we're thinking about Kawasaki, right? At that point, you would recommend the parent bring their child to the ED. But otherwise, here's some really common causes of fever. Vaccine reaction is very, very real. And then viral infections, always like a default. Bacterial infections, if you have an associated focal finding, the kid's really sick. And then the less common things that you think about for longer fevers, usually at that point, you will have sent them to the ED to do a Kawasaki workup, but liquid cancers, rheumatologic diseases with associated symptoms. Next. And then this is just a quick breakdown of pediatric rashes. So acute, you're thinking your body is reacting to something, right? Whether that's like an allergen, either that's like an internalized allergen from IgE-mediated reaction or contact dermatitis, or sometimes like chronic intermittent urticaria, the hives that like we may not be able to find an etiology for. And then of course, in terms of acute rash, you're gonna have infections. So that's like viral exanthems, molluscum, impetigo, tinea, etc. And on the right, for subacute, like eczema, subacute and chronic rash, eczema, psoriasis, right? So you're looking at, is there like big, like thick scale? That's something that helps differentiate it from eczema. And then seborrheic dermatitis, which is like the yellow crusty stuff, which is more seen in younger infants, but can occur in children as well. Cradle cap. And then acne, which can occur in younger children in addition to teenagers. So all of these things are things to think about when a parent brings in their kid to you for rash. Next slide. And this is just my like chart of all of the different steroids that you could possibly prescribe. Generally, I have never prescribed anything higher than class 3 for children. And if you're considering that at that point, you should obviously be referring them to dermatology. Cool. Next slide. Ooh. Can you go one more? Yes, here we go. Okay, so growth abnormalities. This is on the left an example of somebody quote unquote falling off the growth curve. There are many different definitions of growth abnormality or like poor weight gain, etc. But generally, most folks will go with like this person is crossing 2 percentile growth lines, right? So then what are we thinking about when this happens? This is directly copied from a lecture that I got from our pediatrician, resident pediatrician, which is, first of all, there's like a very normal and like familial like variant where somebody just like will like drop kind of like 30 maybe like 30%, and that is like that might be fine. And then there's like truly problematic weight changes, which is like from malnutrition, which is which is insufficient calorie intake or absorption, which can come from a variety of different reasons. And so the first one is more of a like, you get their family history, see if this is common in their family, and then maybe a diagnosis of exclusion once you've like had a sufficient history and potentially lab workup to make sure that the latter is not happening. Next slide. And then height. This is also just like a quick thing. One time I had a parent who came back to me and was like, I had been reassuring her about her child's height because it was just like her family, like her parents were short, and their like mid-parental height was projected to be around the percentile that the kids, exactly, yep, the 2 times speed. It's happening, the kid was projected to reach her parents' mid-parental height. And I was like, this is just normal. Your kid is going to be short. I'm sorry you did this to them, but it's not their fault. And then the parent came back to me and was like, I took them to China and like took them to this hospital and they got all this work up here. It is all in Chinese. And I was like, why did you do this? So the things that the parent did were the bone age, right? Because if you have delayed bone age, then you're going to have like constitutional growth delay or growth hormone deficiency. If it's a normal bone age, the bone age is keeping up with the child's age, then you're less concerned about a pathological process. This kid's bone age was normal. And then you're thinking about like hormone testing and such if you're in the like abnormal bone age category, but that is a big differentiating workup. Next. And speaking of growth, I will now be turning it over to Dr. Wentzel to talk about eating disorders.
Thanks, Leena. So just a heads up, this is not a comprehensive review of eating disorders. And I also wanted to put a disclaimer that this can be very triggering for some people, especially if you have personal experience of ED. So like, please take a break if you need to. This should last about 5 minutes. So I just want to put that out there. So when speaking of eating disorder screening, you will screen for this at every visit. Really paying attention to how your patient talks about their weights, their eating habits and how they view their body, as well as the way that they use and view exercise. And so a good way to screen for this for pediatric patients is actually like through the shades portion of the physics, especially in our adolescent patients. Like there's a specific portion that talks about like activity, dieting, and then in our clinic, we have dot phrases, and there's one a couple questions specifically talking about how the patient feels about their body. Other signs that you can cue into is the objective data, including weight, height, vital signs, and physical exam findings, which I'll have like later in this presentation. But I will say that the objective data doesn't always tell the full story, and really what's important is how the patient views their body and their weights. And I also like challenge you to be conscious of your own anti-fat bias. Anti-fat bias is very prevalent in medicine, and it leads to the underdiagnosis of ED in patients with larger bodies. Next slide. And so these are some physical exam findings that may be consistent with like decreased food intake or malnutrition, purging, and excess energy intake. And these are probably some exam findings that you may be familiar through medical school. This is not a comprehensive table, but something that you can look at during your own time. Next slide. I just want to do a very quick, brief overview of the different eating disorders. There are 5 listed here, but there's also many other subtypes of these major 5. And so with anorexia nervosa, you're really looking for low intake, low weight, and or significant weight loss. Low weight is does not have to be present. Actually, the BMI definition of anorexia no longer exists with the newest guidelines, and you're also looking for intense fear of weight gain as well as behaviors that interfere with weight gain as well. And then I would say universally across like anorexia and bulimia is this, as well as like recurrent purging disorder and binge eating disorder, is this altered view of one's body as well as their value. For bulimia, there isn't low intake, but the patients experience lots of binging and then something to compensate for the binging that they are experiencing. So that might be vomiting, laxative use, exercise as well. Recurrent purging disorder, similar to bulimia, where they have the compensatory behaviors, but they don't binge. And then with binge eating disorder, just binging, but no compensatory behavior, so no excessive exercise or using like medications to help. And then avoidant restrictive food intake disorder. This is the only one that's not really connected to the patient having concerns about their body, but it's more about how they experience food and how that leads to them not wanting to eat and failing to meet their nutritional needs. And then as a disclaimer, a lot of times eating disorders coexist with other mental health conditions like depression, anxiety, and trauma disorders, and kind of realizing that like these disorders can be a manifestation of how patients are trying to regain control in their lives through their bodies. Next slide. Management for ED, I think the first thing is really to stratify what level of care that your patient needs. There's like basically 4 levels of care. There's hospital-based programs, there's residential programs, day treatment programs, so partial hospitalization, as well as outpatient treatment. So something that occurs in the clinic setting, and this really depends on the degree of malnutrition that you're observing, how much insight the patient has in their medical condition, as well as motivation to get better. When you're managing these patients outpatient, it's really important to have an interdisciplinary team, including you, a dietitian in your clinic, as well as a behavioralist. And then, after a certain period of time, if you're noticing that your patient's not improving, not gaining weight, then making an early referral to a day program or hospitalized setting. And the reason for this, I think hospitalization is very difficult because it can be very traumatic, but there is data to show that early referral to intensive treatment when it's needed can decrease mortality from these conditions. And then also not setting a specific number for management, but really weight ranges Also moving away from calorie eating to more intuitive eating and eating more calorie dense foods. All of these interventions are combined with psychotherapy. There's no data to show that medications should be used for the treatment of ED, but if there's a concurrent mood disorder like depression, anxiety, like of course you're going to treat that. And then bone mineral density, like dental erosions are all a concern. So making sure you're providing those other adjunctive treatments for those patients as well. Next slide. And then this is just a quick table showing what features that you would be concerned for on exam that would necessitate hospitalization. And the biggest ones are like if you see any ECG abnormalities, electrolyte disturbances. Another one is if they fail outpatient therapy, as I mentioned previously, and if they're just not eating food at all. And I'm going to hand it over to Ryan.
Oh, hello. Yeah, so thanks so much, Sunmi. We're going to talk very briefly about all of prenatal care. There's so much to talk about, and this is really one of the few times that we see patients so regularly in clinic. You know, for a lot of other issues, it'll be like an annual visit once a year, or hypertension, diabetes every 3 months. But for prenatal care, you know, you're really kind of seeing patients for like almost a dozen times in the span of 6 months. So we will really try to talk about like what are the most salient points throughout these visits. So the very first visit, you know, patients are like, I think I'm pregnant. I don't have my period yet, and I've been vomiting. So this is often like a 20-minute visit or so, and you have to do like 5,000 things. So first and foremost, what I would recommend is doing the ultrasound at the very beginning, because the last thing you want to do is like go through their history to figure out their LMP, whether they're regular or not, if they've had surgery, like what is their obstetric history, like is this their first pregnancy, and talking about like all of the little counseling things. And then you do the ultrasound at the end and you're like, oops, actually you're not pregnant. So I would definitely do it first. Most of the time you do want to try to do the transabdominal approach just because it's less invasive, and if you can get the information that way, then great. Oftentimes, if they're super early in their pregnancy, like 5-6 weeks, you may not be able to visualize everything. So in those situations, you would have to switch to the transvaginal approach. So the way that the ultrasound works, actually, for the transabdominal, you want their bladder to be full. And so when they're getting room, just make sure to have your MA say like, don't go to the bathroom right now. And that kind of helps like visualize the uterus from the transabdominal approach. Once you're there, you know, based on the age, you'll need to identify landmarks, and this is like a whole separate topic, but basically as long as you can see the crown and the rump and you can get that length, then perfect. If not, you tell them, go to the bathroom, we'll do the transvaginal now. For dating, if your estimated gestational age is less than 9 weeks, the ultrasound should theoretically be within 5 days of the LMP. If it's greater than that in terms of discrepancy, then you use the ultrasound dating as their new due date. If they're greater than 9 weeks, then it has to be within 7 days of their LMP. So after you've established, like, great, you're pregnant, then you want to go into options counseling. And what that means is asking without judgment, like, hey, so it looks like you have a pregnancy. How do you feel about that? Would you like to continue? Because as you know, some people, pregnancy is desired, and at other times it's unintended. And so kind of walking patients through their options in terms of like if they want to proceed or if they want to terminate is our job as the first doctor who's seeing them for their pregnancy. And then beyond that, you kind of have to talk about all of their other stuff. So whether they've been pregnant before, how did those pregnancies go, if they have chronic medical conditions, if they take any meds, OTCs, herbal medicines. And then you have to take like 5 1.5 billion lab tests. And so they're listed here, but the main things are like, do they have issues with their blood? Are they infected with any sort of viruses or bacteria? And then also screening for like genetic disorders. I think within the last year, the recommendation had changed via ACOG to include hemoglobin electrophoresis and an alpha globin gene analysis. And so that's something that we've been adopting at our clinic. And then one thing to note is genetic testing. So a lot of people, they will want to test for trisomies, so like 13, 18, 21, as well as the sex of the baby. And even now, Medicaid covers the cell-free fetal DNA. The earliest that that can be done is around 9 weeks, but it's really 10 or later is better. And so oftentimes I will tell people like, here, you can do all these blood tests. You should wait until you're at this gestation before you get your blood drawn though. Next slide. So throughout the pregnancy, there are 4 main questions that everybody should be asking. I'm sure many of you are aware of these from your third-year rotations. But if any of these are abnormal, the patient has a medical emergency and they should be seeking other care. So are they having any bleeding, any leakage of fluid, aka like has their water broken? Are they having any contractions? And if there's feeling fetal movement. And so just make sure at every single visit, you should ask all 4 of these questions. Next slide. So going by trimesters, in the first trimester, you're seeing patients on a monthly basis. Miscarriage management is really important because 10 to 20% of pregnancies end up as a miscarriage, and so it's way more common than people think. And so just like making sure people understand and can recognize the signs of a miscarriage is really important in these first few visits. The other thing is oftentimes people have a lot of nausea. The first line is actually vitamin B6 or pyridoxine, and there are many different permutations on how you can prescribe this. And so oftentimes that ends up being a conversation with the patient of like, okay, do you want to take this med 4 times a day? How about this other thing? And so, and of course you can always offer, you know, like ginger or teas or other herbal things as they want. And I'd already mentioned here, but the genetic screening, almost always we're just doing cell-free fetal DNA these days, so you don't have to look up the quad screen or any of that kind of stuff. And then at 12 weeks, you can start to hear fetal heart tones. So that means taking the Doppler, the very, very small ultrasound, putting it to the suprapubic region and just listening to heart tones. And heart tones should be 110 to 160 beats per minute. Next slide. So in the second trimester, this is kind of when people are smooth cruising, they're feeling way more comfortable and they're like, oh, okay, being pregnant's not so bad. You're still seeing them every 4 weeks, and there are just a few major milestones here. So the 20-week mark is kind of like halfway through their pregnancy, and they should be scheduled for an anatomy ultrasound to make sure there aren't any fetal anomalies. And then at 24 to 28 weeks, we're doing a glucose tolerance test. So basically, the patient arrives for their visit. They drink this horrible juice, which it's like a tiny Gatorade bottle, and they got to chug that thing, and then they're going to see you. And at the end, 1 hour later, they're going to get 1 blood test. And the cutoff for an abnormal glucose tolerance test is actually dependent on your institution. Some people are like, greater than a glucose of 135 or 140. So just make sure to do whatever your institution is recommending. And then if it's abnormal, then they have to do the 3-hour. And then at 28 weeks, we often recommend like 1 blood draw. So that's an anemia screen and a Tdap. And then I forgot to include it here, but there's also the RPR for syphilis screening. Next slide. And then in the third trimester, this is where things start to ramp up. You know, patients are gaining a lot more weight, which is expected, right? And so in pregnancy, oftentimes people are gaining 1 to 2 pounds, depending on their BMI per week. You're increasing the frequency of visits to Q2 weeks up until the 36-week mark, where you will do every 1 week. And then you'll do a GBS swab, which is a swab that goes in the vagina and then in the rectum. And this is kind of the point where you have less urgent, timely things and more time and more visits to really talk about the counseling part of things. So what they want their labor to look like. Are they interested in epidurals? Do they want to breastfeed? And just talking about like what labor looks like, going over how contractions are like expected to feel, and at what frequency they need to be for patients to then say like, oh, I need to go to triage. So yeah, that's kind of like a super brief overview.
All right, so we talked about what to do when someone's pregnant, and now I'm going to talk about how to make sure someone doesn't get pregnant if that's not what they want. This is one of my favorite charts from the California Office of the Surgeon General, and it lists basically every single method. Bottom is least effective, top is most effective, and you can see this includes withdrawal or pullout, fertility-based awareness, which actually can have like an 80% success rate. I would never tell a patient that, but don't stress out too much if that's what they tell you that you're using. Next slide. This is a different version of that. You're welcome to save this table, but I also recommend making your own. And it basically includes every single method, sort of like time, because that affects a patient's choice a lot, sort of like whether they're thinking about taking something daily versus like putting something in, not having to think about it for 10 years, right? And the method of action, which sometimes is not intuitive. So reminding of yourself, like this one thickens the cervical mucus, this one actually stops ovulation or doesn't, because patients will have that question. And then like counseling about different side effects. And I just want to make a comment, of course, that the top row is all the combined hormonal methods, which means estrogen and progestin, right? Estrogen is what causes the increased clot risk. And so these methods are sort of contraindicated for somebody who just had a baby because they're also still in a high estrogen state and at a risk of clots. But also for smokers, folks who have migraines with aura, lupus, heart disease, breast or endometrial cancer, and liver disease, anyone who's hypercoagulable, or at risk of increased breast cancer, endometrial cancer. And then all the rest of the methods are progestin only with varying levels of progestin, which is also why they may have like more bleeding abnormalities. The estrogen sort of like helps regulate the bleeding as well a little bit for the oral contraceptives in the patch. And then for all methods, when you're starting, we recommend a urine pregnancy test at that visit if the patient has been sexually active prior to your visit, because if they are pregnant, then you're having a different conversation, right? And then for the non-IUD methods, we do recommend a backup method for the first 7 days because it doesn't really kick in, or like you can't guarantee. It probably does kick in a little bit, but you can't guarantee 100%, like the 99% effectiveness of those methods. Next slide. This is a slide of the different IUDs, which you, again, can learn to put in as a family medicine doc, and they are effective for different years. Obviously, some of them have higher hormones than the others. Paragon has no hormones at all, and so that might be important to your patients when you're counseling. Next slide. And also, some of them serve as what we call sort of like emergency contraception, aka somebody had unprotected intercourse. They want to make sure they don't get pregnant, and you can offer these to them if they're within like the 5-day range. Even somebody has options, and Liletta and Mirena are now able to be used for emergency contraception, which is fantastic because usually in the past the only thing that we could use that immediately worked as birth control and as EC was the copper IUD. Now folks have more options, which is great. Don't forget about Ella, which is 5 days as well. And my favorite, the ultimate birth control, thank you for moving to the next slide, is vasectomy or tubal ligation. And vasectomy, again, is a family medicine, like okayable, like doable procedure, something that we can do in the office, doesn't require, general anesthesia or a scalpel. It's a local block and cautery situation. And yeah, something you can learn to do and be trained to competency depending on your residency and like where your preceptors are at. Of course, tubal ligation and hysterectomy are like full OR things, and that is not something that we do, but we can definitely counsel patients on them. And like there are also there's like website listings of like gynes and local gynes who are like willing to do that for folks without being like too obnoxious about like, well, are you sure you don't want kids? So you can look those up in the internet as well for your local area. And also, as I was saying, so birth control methods, right? A lot of them are really, really effective, but the most effective ones do not also like protect against STIs, right? So only barrier methods, internal, external condoms, diaphragms, internal, external condoms are the ones that would really help with STI prevention. So now we're going to talk a little bit about infections. Next slide. So a patient comes into you and they're just like, I had unprotected intercourse, or I have been for a while, and I just want to be tested for everything. It's just like my regular checkup. I just want to know if I have anything. So they're like, they don't provide any suggestions. So as the provider, you're just like, okay, what am I ordering? Gonorrhea, chlamydia, right? And all relevant orifices, whatever ways that they are having intercourse, because they can be, you can obtain them in any orifice that's a mucosal surface. HIV, syphilis, right? These are pretty big ones, the serum testing. And then hepatitis C is something that people don't think about a lot, but it should also be considered an STI and should be tested for if you're already drawing blood anyway. And then how do you counsel the patient about the timing, right? So I always tell patients, it can take up to 2 weeks and sometimes more safely, like 4 weeks for these lab tests to show up positive if you contracted one of these infections like at that time of intercourse. So if you just had intercourse yesterday, I'm happy to test you, right? But if that is the encounter you're worried about, I recommend you come back in 2 weeks to be tested again, because that might be the time where something actually shows up on your tests. And hepatitis C takes even longer, right? So that can take like even 2 to 3 months. So that is why we recommend folks get like tested regularly if they are having sex that puts them at risk. Next slide. And then things that you can consider depending on someone's symptoms or depending on if they're just like worried and want to like get extra testing, folks might be at risk for vaginitis. Trichomonas is actually considered an STI, genital herpes, hepatitis B, HPV. We don't recommend like testing outside of sort of the routine like cervical screening timeline that Justin talked about. There are clinics in the US now that are offering like rectal cytology and exams for folks who are having anal intercourse and are at higher risk of like anal cancers, but most clinics don't have this set up. And then quick plug for the Gardasil vaccine. Most insurances cover it up to 46 years old. And someone should still get vaccinated, even if they're like, well, I'm like old and I've been having sex this whole time. Like if they're going to be having new partners, it is still recommended to get the vaccine. So next slide. And then what if someone says, I had unprotected intercourse and I'm really worried about it, like it was non-consensual, or I don't know anything about this person, or whatever. They just feel like they had like unprotected intercourse really close to the time that they're seeing you and they're very stressed about it, right? So you can offer post-exposure prophylaxis. So that includes prophylaxis for chlamydia, gonorrhea, HIV. Ryan's going to talk more about PrEP, which is pre-exposure prophylaxis, but you can also give post-exposure prophylaxis, of course. You can offer like vaginal like prophylaxis as well.
Oh, yeah.
For
I love it. Where did you get it? My friend got my birthday. You don't know we got.
Someone's
dang, so cute. Cool.
Carissa? Oh, she mute? Okay. Great. Or whoever, sorry. And then you would repeat testing, right? Because A, there's a risk that something wasn't fully treated if it was contracted, and B, somebody who gets an STI once can possibly get it again. And then, of course, remembering that trauma-informed care is a huge part of this process. You are taking swabs and samples and things from very sensitive areas. Offer patients the option to self-swab, like vaginal and like rectal areas, if like they're able to. That can be a really, really great thing. Next slide. Yep. And then I just want to do like a quick symptoms to differential, sort of like what areas are you thinking about are infected and like what can cause infections in that area depending on the patient's symptom, right? So the earlier scenario, someone's asymptomatic, just wanted screening. This would be more like diagnostic testing. So dysuria, depending on their like genitals, you'd be thinking UTI, vaginitis versus proctitis. And you'd be thinking about gonorrhea, chlamydia, or just like a bacterial like UTI. Vulvar or vaginal pain or itching or cervical friability will make you worry about vaginitis or cervicitis. Rectal pain, discharge tenesmus, again, makes you worry about proctitis. And for the vulvar stuff, you might be thinking more of a wet mount. And then for pelvic pain, fun fact, the definition of PID, right, pelvic inflammatory diseases, is anything higher up in like sort of the female like anatomic, genital urinary anatomic area. So like endometritis, appendicitis, tubo-ovarian abscess, pelvic peritonitis being the worst outcome, of course. So pelvic pain plus cervical motion, uterine or adnexal tenderness doesn't have to have fever. You just treat it. You just treat it because PID is like can be so bad in terms of like life consequences, and also fertility. And then I'm going to talk a little bit about genital rashes and ulcers in the next slide. And there are about to be pictures, so I'm sorry about that. So if you have one takeaway from this slide, basically painful ulcer, probably herpes. Painless ulcer, syphilis until proven otherwise. And then there's like a bunch of stuff in between. You can have genital warts. Obviously, there's like more bumps than like ulcers. And then the other things like lymphogranuloma, venereum, I've never seen, but is definitely still out there in the US. And then chancroid is like rarer here, more common in developing countries. And I'm just going to show a quick picture of, I think, herpes. Yep, this is with the vesicles, right? And then this one is a syphilis chancre. So you can see that they're like mainly it's like the vesicles, no vesicles, but symptoms are really, really what you're going to be listening for. Next. And then this is just a treatment chart. It's like, uh-oh, I tested, it's positive. What do people do? Just remember in general, like if a patient has one of these and you haven't tested for the others, test for the others because STIs hang out together. And then a lot of these are public health reportable, right? Because the public health department is going to want to do contact tracing. Your clinic might already have a setup for that, but you need to figure out what it is. And then just a fun fact for folks who have vaginas who are having intercourse with each other, trick, BV, and HPV are considered STIs. So trick is a public health reportable, and then for BV and HPV, you may want to just counsel like folks about like partner treatment as well as like cleaning like different like toys and stuff that may have been used in the process of intercourse. Next slide. Okay. That's my portion. Off to Ryan.
Thanks, Lena. So I'm gonna go over abortion care. If this is something that's triggering to you, of course, take a break. We'll be kind of covering this for the next 5 minutes or so, but thanks for bearing with us. So next slide. Basically, for abortion care, in residency, your training will differ pretty drastically depending on if your residency is a ready site or a ready affiliated site. And if neither of those are true, then this may be an area of growth for you after residency, or you may need to do a fellowship. So there are two major ways to undergo abortions, and these are for people who, like Lena had just mentioned, like the day after, or emergency contraception within 5 days, using a copper IUD, other IUDs, pills, etc. And so this is like beyond that. People discover that they are pregnant, they do not want to continue the pregnancy. So there are two main routes. There is medical abortion and surgical or procedural abortion. So for medical abortion, most of the time we use two different medications. We use mifepristone and misoprostol. This is an option for up to 10 to 11 weeks of gestation. And on day 1, you give the mifepristone. And then on day 2 and 3-ish, you use buccal misoprostol, so within the cheek. And so the mifepristone, it blocks progesterone, which stops the pregnancy from continuing, right? Progesterone to progress, and it blocks it. And for the misoprostol, that helps the cervix kind of soften and ripen. In addition to the misoprostol, we strongly recommend taking pain medication as well as nausea. And so most practitioners who do medication abortions, they will also be like, and we're going to give you ibuprofen and Zofran, and you should take these around the clock for the next few days. If the pregnancy is beyond 9 weeks of gestation, that person may need an additional four tablets of the misoprostol 4 hours after the initial dose. And in all these cases, they probably will pass the pregnancy within 24 hours. That being said, the cramping and the bleeding can last for weeks, and sometimes patients have bleeding for 8 weeks after medication abortion. 2 weeks after, they should have an ultrasound scheduled to confirm that the pregnancy has passed and is no longer intrauterine. And so you can stay here, but the reason, when you're counseling patients between medication and surgical, oftentimes like it's based on their preference. So for people who are like, I don't really want a procedure done, I kind of want to be in the comfort of my own home when I do all this stuff, I want to be surrounded by my people, medication may be better for them. But some people, they really want to opt for an option that ensures that they leave the building and they're like, I am no longer pregnant. Also, the course of bleeding is shorter with the surgical abortion. So I'll briefly go over the process of this. So from most of the time, at least for family medicine folks, these days, it's really hard to find surgical abortion training that is beyond the first trimester. And if you are hoping to do that, you probably will need to do a fellowship, or that may just end up being within the realm of OBGYN, wherever you're practicing. Up to 12 to 14 weeks is kind of the tipping point of where it is outside of our scope. most of the time people will give doxycycline, ibuprofen, misoprostol for that cervical ripening again, and Zofran as well as a benzo. And the whole process, people will walk in the door, then they will get an ultrasound done to confirm, like, yes, you are around this gestational age. Then when they finally come to see you after they jump through the hoops of whatever your state's legislative body requires of people to go through, you will then meet the patient. You'll do a bimanual exam to make sure is which way the uterus is pointing to help guide the rest of your procedure. You'll do a cervical block. Most people do this is the super long needle that many of you probably have never seen. Actually, if you click the button, it'll show a picture of it. So it's the one all the way. Oh, actually, this one does not have it. But all the way on the left, that is the type of syringe that we use for cervical blocks. It doesn't have the needle extender on it, which is what we often use at Planned Parenthood. Depending on your preceptor, they'll say, do it at 10 and 2 on the cervix. You'll visualize the cervix and they'll be like 2 o'clock, 10 o'clock or something. Or they'll be like 12, 3, 6, 12, 9. And it really, it varies per preceptor and your just preference, basically. Beyond that, then you'll use the dilators to dilate to whatever gestation. And so if you go back to the picture again, at the bottom, there are these dilators, and they're just these metal rods that are slightly curved at the end. And each rod is actually 2 sizes. So the bottom one is, if I were to guess, is probably the 5 and the 6, and then it goes 7 and 8 for the second one from the bottom, and then 8, 9, etc. And basically what you're doing is you're feeding the end of that probe through the cervical os, and you'll feel resistance when you get to the internal os. And then as soon as you get through the resistance, that means great, your probe has made it through the internal os. And that's when you'll retract and switch to the larger size. And the size of the probe should kind of match the weeks of gestation. So if you're doing an abortion for a 7-week gestation, you will need to dilate to a 7. And so it's pretty simple in that regard. And then based on the gestation size, you will either do an MVA or an EVA. So MVA being mechanical aspiration. And that's the one that's shown on the screen right now on the left-hand side, with the 2 kind of prongs on the ends that are plastic. And I'm sure many of you have done the papaya workshop, but basically you insert the aspirating tip through the cervical os, and then you release the lock so that there's suction, and you kind of do this back and forth motion, rotating in a clockwise fashion until the texture feels gritty. And sometimes it takes 2 or 3 passes before you get to that point. So that's kind of an overview of abortion care. And I'll leave it to Sunmi.
Okay, great. Sorry, I was just finagling on my little windows. So I will be talking about gender affirming care. Just a disclaimer, this is a very, very big topic, and it can basically be a multi-day conference. And so the goal of today is just to quickly review some of the hormones, what your visit structure may be like, and then also just have a good set of resources that you can refer to later. But just as an overview, gender affirming care can involve a whole lot of things. It can include hormones, surgical interventions, non-surgical interventions, such as hair removal, voice therapy, tucking, packing, binding. It also includes preventative health, mental health, as well as support in legal identity documents. And you can go to the next slide. So for the initial visit, it's so important to make sure that you have a clinic environment that is safe and affirming for your patients to come into, making sure that your staff is trained in transgender and gender diverse health issues, making sure that like your clinic area is very inclusive, having the availability of gender neutral bathrooms. It's very distressing not to have a bathroom that you feel comfortable using. And then also, this isn't something that I have come across yet, but I would think that if you do have a patient who requires interpreter services, just briefly like debriefing with your interpreter before you go into the room about the preferred terminology, maybe going over neutral pronouns and just staying away from like gendered language, and then reflecting what your patient is using. And this is something that Ryan does similarly when it comes to like abortion or pregnancy care. In terms of starting gender affirming hormone therapy, there's like criteria that's been like outlined by the WPATH that a lot of clinics have adapted. So like the patient reporting like persistent gender dysphoria, the guidelines are like having it documented for at least 6 months. It's not necessary. A lot of your patients will say that they've been experiencing gender dysphoria for years, maybe their entire life. The patient has the capacity to fully consent and make informed decision. They are over 18 or the age of the majority. If they're a minor, that goes into a totally different category of gender affirming care that is completely valid and important, but also varies by state laws here in the US. And then in asterisks, like their medical concerns are reasonably controlled. In most cases, you will not withhold gender affirming care because of medical concerns, because in most scenarios, gender affirming care is medically necessary. It can be life-saving, and denying them care can worsen depression, anxiety, SI that may exist, and cause them to disengage from medical care, or also look into like unsupervised like hormone use or procedures. So just keep that in mind and make sure that you're having a nuanced discussion with your patients who have significant medical concerns when you're talking about their care. And then the most important part is getting to know your patient. And these are just a set of questions. It's not comprehensive, but it's really about getting to know your like what your patient wants to be called, their pronouns, what their story is, what their goals for gender affirming care are. Like, have they tried hormones in the past? What hormones have they tried? Are they considering like surgical procedures later on? And then kind of frequently checking in about if these like goals are changing over time versus not, and how they're feeling about their treatments. And then another thing that I want to bring up that I feel like is often missed is talking about the patient's fertility and repro goals. I think so far a lot of the literature shows that it doesn't affect fertility as much, but there's not long-term data. And so just being very transparent with your patient about that, and also recognizing that if they do any fertility conservation measures, it is very expensive, but everyone deserves the right to make that decision for themselves. Next slide. Before you, depending on like what hormones the patient wants, you may consider getting some screening labs. If they're initiating testosterone, you definitely want to check their CBC, look at their hematocrits, and monitor that during treatments. And then when it comes to initiating estrogen or anti-androgen treatments, there's not really a lot of screening labs you have to look into unless you're starting spironolactone, which is usually not during the initial visits. And then maybe you'll check like a urine HCG if there's any possibility that the patient may be pregnant. Next slide. So this is a slide about the different estrogen and anti-androgen treatments, also referred to as feminizing hormones. So basically for estrogen, there's like three major like routes they can deliver estrogen. They all have their benefits and drawbacks. I think the biggest thing is that a lot of your patients will have done their research, they have friends in the community, and they probably have thought about this for a very long time and may have an idea of what they want. But just a brief overview, oral estradiol can be really great because it's cheap. They take it every day. They have steady levels. Some people prefer injectables because they feel that it's more effective. And also just like kind of mentioning the nuance that I was learning when I was putting the slide together is that estradiol cypionate might have like like longer later peak level, so like potentially less fluctuations during that cycle. But these are all options. And then usually you'll start with an estrogen therapy and then you'll add on the anti-androgen treatments. If the patient is not like quite meeting their goals. So you can consider like spironolactone, a 5-alpha reductase inhibitor, and then the big glucosamide, which I haven't seen very much, but is also an option. Next slide. And then you have testosterone treatment, or also known as masculizing hormones. Similar to estrogen, it comes in a lot of different forms. The injectable form tends to be the cheapest formulation since it's been used for a long time for male hypogonadism. Just of note, similar to the estrogen formulations, the cypionate and epinate, the biggest difference is that they're compounded in different oils. So if you find that like your patient's having a local reaction, maybe switching to the different testosterone formulation for that could be helpful. If they're using the transdermal formulation, just counseling them about like contact with partners, children, or pets, especially after they apply it to the area. And then once your patient has been stabilized on a treatment, you can also talk on testosterone. You could also offer them like implants, which is a minor surgical procedure they can do in clinic. And then there's the oral testosterone capsules. This is relatively new. It's very, very expensive. There's no generics, but still important to talk about. And then just going back, one slide, so progesterone should be mentioned on the previous slide with estradiol and the anti-androgen treatments. You may consider progesterone if the patient has been on estrogen for about a year and they want like additional breast development. It's an anecdotal thing, but still important to offer and consider. And if you do prescribe it, prescribe the micronized formulation of it. And you can go forward. Okay, so monitoring. Once you start therapy, you want to monitor your patient about every 3 months. At that time, you want to check their labs, make sure that their labs are within the physiological range for cisgender, male, female, respectively. So this is the one for testosterone use. And then if you click one more time, there's a table for estrogen or anti-androgen use. Next slide. This is a slide with additional resources for our patients and for yourself. So I love using these. Well, I love to use the Fenway Institute as kind of like a quick questions in clinic, looking at starting dosages and like how to up titrate or looking at the frequency of lab monitoring. The UCSF can be also a good website, but it's slightly outdated. Also good for quick questions, and it's pending revisions this year, so hopefully that comes out soon. And then the WPATH is like the big mama organization for gender care, and it's really great for answering those more nuanced questions. I also want to point out this resource called the Trans Lifeline. It's the only like crisis line for trans and gender diverse folks. And then the National Center of Transgender Equity. These are all links. If you click this, it will give you like state-specific guidelines to change different legal documents as well as like federal documents like your passport and things like that. And then here are some resources for advocacy too. Highly recommend looking into local organizations in your community. Next slide. And I'm done. Yay, Ryan, your turn.
Awesome. Yeah, so I'm going to briefly talk about HIV care. And this is something that everybody will need to know about because it is an USPSTF recommendation that everybody be screened. So basically, who should be screened? Every single person who's pregnant with every single pregnancy, and then otherwise when you're 15 to 65 years old, once in your lifetime. Next slide. There are two different things to think about with HIV. One is preventing it, and the other is treating it. So as probably all of you have heard of PrEP is pre-exposure prophylaxis. Basically, it's medications to make sure that if you come in contact with HIV, you do not contract it. For HIV treatment, there are 5 billion medications. This has been developing for at least like 30 years now. And so oftentimes we end up giving people a combination of 3 different medicines. Next slide. So who should get PrEP? Basically, anybody who wants it. There are certain populations who are at higher risk, but if your patient comes in and says, "Oh, I want to have PrEP," you should be like, "Okay, sounds good," because there is really no like contraindication. Like if people are interested, they should just have it. There's really very little harm, which we will talk about a little bit later. But risk populations, or like people who you want to like keep thinking about, like, maybe this is someone that I may want to bring up PrEP to, are people who have partners with known HIV infection, if people have more than 2 partners with unknown statuses, if they have inconsistent condom use, STIs in the past 6 months, or they share injections, needles, or other equipment. Next slide. So for oral PrEP, there are 2 formulations currently. They're listed as emtricitabine, tenofovir, disoproxil fumarate, or Truvada, and then emtricitabine plus tenofovir alafenamide, which is Descovy. And so, Truvada is kind of like the tried and true, the first one that came out, and there are kind of like risks in terms of whether or not you have an eGFR less than 60, and also there's a question mark about like bone and renal stuff long term. Descovy, honestly, the labels say, oh, it's better because the recommended eGFR cutoff is 30 or less, and so like theoretically there's a lower risk for renal disease, but actually the data is really not that strong, and so both are quite comparable, and Descovy is just more expensive. So in my practice, technically, I personally just opt for Truvada unless patients feel strongly otherwise. And also, interestingly enough, the studies for Descovy have never been in people who have receptive vaginal intercourse. So take that for what it is. Next slide. There is a brand new formulation for PrEP, though. It's called cabotegravir. The brand name is Apretude, and this is an injectable PrEP. And the benefits of injectable PrEP is you don't have to take a pill, right? Some people, it's really hard to continue taking pills every single day. And so this is an alternative where, they have to come to the clinic to get an injection right now. Hopefully that'll change in the future, but this is for people who may have a harder time adhering to a daily regimen. And so the formulation is as follows. Basically, for the first 2 months, you give the injection in the first month, which is basically like a loading dose, and then they come back 1 month later, and then from then on out, it's every 2 months. For patients who may have side effects, it may not be the best idea to give them an injection that'll last for an entire month. So for patients like that, you instead would start with an oral lead-in, and so you'd give them cabotegravir orally for 28 days, and then if they're like tolerating it really well, then you're like, okay, now we can inject it. And so it's basically the same exact formulation or like schedule, but shifted 1 month later. Next slide. So HIV, this is like a super, super long topic that we could spend hours and days and years talking about. But I'll just briefly go over. So for HIV, one of the things that we worry most about is resistance patterns. In the past, there have been like a lot of different medications, a lot of different formulations, and over time, people then when they for one reason or another, resistance develops, and then that resistance is passed on. And so one of the key things with treating HIV is figuring out what sort of resistance patterns does this patient's brand of HIV have. There are 2 different tests for it, and honestly, I have not really done this outside of the context of like the specialized HIV clinic that I go to. But GeneAssure Prime, basically, it's looking at the RNA. So like if you have active disease, there's a viral load greater than 500, you have the virus floating around so you can test it directly. But if patients are suppressed and they're on medicine and their viral load is low, then there's nothing to test, right? And so that's when the GeneAssure archive is relevant. And so you're really like looking at the host DNA because it's a retrovirus, so the HIV like is embedded in the DNA, and so you can look at it in that regard. But like once the virus replicates, then it can kind of alter itself, and so oftentimes the prime is more accurate. Based on that, of course, you would treat with whatever medication the HIV is not resistant to. And most of the time these days, actually, almost everybody, unless they have a resistance to these meds, is on Biktarvy, which is a combination of two NRTIs and an integrase inhibitor. And the side effect profile is very, very low for this new medication. One other thing to note is what is the goal? The goal is U equals U, which is undetectable. So you give them a medicine, the HIV viral load goes down, and when it is undetectable, then it equals untransmittable. And that is a really important point to talk to your patients about, because there's so much stigma with HIV, like this has kind of been like a social movement in a lot of ways, and kind of persecution in some regards. And so just like empowering your patients to live their lives and acknowledge like actually it's quite low risk if you want to do the things you want to do, as long as your viral load is undetectable. So I'll pass it back to Sunmi.
Yay. So this is also one of my favorite topics. Also very big topic. We will not touch on everything. The two things I'm going to focus on is alcohol use disorder and opioid use disorder, which are the two things we treat the most in the outpatient setting. And then I feel like with stimulant use disorder, benzo use disorder, it's a little bit more nuanced. And it is mostly psychosocial therapy, because the medications, like there are pharmacological therapies, but not very well studied at this point. Okay, next slide. So for alcohol use disorder, y'all know how to screen for this. Y'all know how to diagnose this. The biggest thing I want to go over is the treatments. First line is naltrexone. It comes in the PO formulation, as well as a long-acting injectable called Vivitrol. The biggest thing to note is you can't use this in patients who are using opioids or have decompensated liver disease. If those two things exist, you may consider a camprosate PO with the fun dosing of 666 TID. Both of them are effective. Based on the data, it seems like a camprosate is a little bit more efficacious when it comes to promoting abstinence, but then naltrexone is better for reducing heavy drinking craving. So really letting this choice be letting your patient choose what they want. I think there's also the benefit of naltrexone being once daily versus 3 times a day for a camprosate. If those are not sufficient in treating your patient's alcohol use disorder, you may also consider topiramate if they have a concurrent seizure disorder as an alternative. Disulfiram, which makes them feel very uncomfortable whenever they drink, by leading to a buildup of alcohol metabolites, or gabapentin. It's a little bit newer one, but it's been shown to be effective with patients who failed other therapies and have previous experience with withdrawal symptoms or are using opioids. It does need to be up titrated slowly, giving it sedating effects, and also just being cautious of the patient's renal function. And of course, all this is combined with psychosocial intervention. That's the most important component. And there's a lot of models for that. Next slide. One of my favorite things is treating opioid use disorder. There's a lot to this. Basically, when you first see a patient who has opioid use disorder, I found in my experience, patients will come into clinic when they want treatment. When they come in, you want to see what their goals are. You want to ask them what their substance use history is. This will really define like what preventative labs you're going to order for them. And then also just seeing like what types of supports and therapies they're in, and making the appropriate referrals to community resources at that time. Things that you want to order, especially if they have a history of injection drug use, is going to be HIV, RPR, Hep C, and Hep B. And then in terms of treatment options, there is methadone and buprenorphine. And methadone is more efficacious, but it's very structured, and it does require the patient to go to a methadone clinic every day until they become stable on it, and then things are spaced out from there. And only methadone clinics can prescribe methadone. A lot of patients may start at buprenorphine first, and then if they don't get sufficient control of bupe, then they may consider going to a methadone clinic from there. Or if a patient just would benefit from that additional structure in their life of going somewhere every day to get their medicine. For bupe, not as effective as methadone in terms of decreasing opioid-related death, but still very great. We can prescribe it in the outpatient setting. It's a lot more accessible. Overall, like compared to methadone, because it's a partial agonist, there's a lower risk of overdose. Plus, it's combined with naloxone in the formulation. There is the PO formulation as well as the long-acting injectable called Sublocade. And then there's naltrexone, which I have not prescribed before, but it can be used for a mild OUD. If you click on the link for the title of the slide, it'll go to the DSM criteria. Basically, how the severity is stratified, it is based on like research data, but basically how many DSM criteria are they meeting? Anyone with physiological dependence will meet criteria for at least moderate to severe opioid use disorder. Okay, let's say you started them on bupe. At every follow-up visit, you're gonna order UDS for them. It's not to be judgmental. It's just to have objective data in informing like the context of their care. If you order this selectively, like whenever you think it's indicated, I think that can be more biased, but also being mindful that you're never withholding care based on the UDS results. You're going to continue prescribing them the bupe. You may, if it comes positive for cocaine, be like, hey, like, have you been testing your substances? Did you know about this? Like, I just want you to be safe. But also recognizing that like maybe practices will change in the future. Having the UDS data has never changed what I do for my patients, and also being mindful that this can be stigmatizing in other contexts outside of your clinic. And I've seen that a lot in the inpatient setting. And then during those visits, you want to review the PDMP, assess for cravings, withdrawal symptoms, relapses. And if they have any of those, you may want to up titrate their dose, give them lots of affirmation. Our patients are trying so hard. This is really hard work. And in the beginning, you might see your patients weekly and then spaced to every 2 weeks and eventually monthly, and monthly with refill, maybe like every 3 months. But spacing out those intervals really depends on how your patient is doing. And so let your patient drive that. And go to the next slide. This is a little infographic that I love to use for bupe home inductions. There's a lot of different ways to do this. It's just one way to show you. I'm not going to go over it. You can review it in your own time, but basically it gives patients instructions of how to initiate buprenorphine. The biggest thing is that they're starting to experience withdrawal symptoms, and by day 3, ideally they're at an ideal dose that works for them. When I do this, I tend to follow up with my patients in about a week. So make sure you prescribe them enough tabs. The math here is like if they come back to see in a week, you should prescribe them about 13 8-milligram film or tablets to last them for that time. Of note, most patients are stable on 8 to 16 milligrams per day, but some people, especially folks who have used fentanyl in the past, may have a higher tolerance and may need to go up to doses as high as 24 or 32 milligrams per day. I think one question that I had when I was starting this type of care is, how often do I dose it? You can do it daily. A lot of patients will split their dosing based on their own needs. So really let your patient drive what their needs are. Next page. This is just a slide about like harm reduction. Just always touch on points of like how to use substances safely and how to inject safely, and then know your resources in your community. Tell your patients where like if your city has like supervised injection sites, where those are, where needle exchanges are. There's a link here to a national database for needle exchange programs. It's not comprehensive, but it's a great place to start. Always prescribe Narcan for our patients. Give it to people who know, who have friends or family who use opioids, and then have fentanyl test strips in your clinic for you to give out. One caveat is that in some states it is considered drug paraphernalia. It used to be in Ohio. And so if it is, you can still give it out. You can recommend them to order it online, and just work to advocate for decriminalizing substance use in our communities. And next slide. Yay, Justin.
Thank you so much. All right, so my last section will be on MSK, musculoskeletal system, which could actually have a probably 4 to like entire conference level amount, but I'm going to cover it in less than 10 minutes. So get ready for 3x, everyone. We're hitting the end, soon to be end of our time together. So now I'm going to insert lots of memes in order to wake people up, because memes are what are useful to connect with people. Next slide, please. So for the MSK system, it's just another huge bread and butter topic for family medicine. The majority, 1 in 2 adults will come in at any point in their life for an MSK type issue. It costs the system about $213 billion a year to treat and diagnose MSK issues. It's important to understand when symptoms are purely MSK versus secondary to MSK, as in a manifesting symptom, versus definitely not MSK. So for example, is something osteoarthritis versus something that's Ehlers-Danlos versus something as a myocardial infarction. For life-threatening versus non-life-threatening, check out the EM Bootcamp. Next slide, please. So the biggest thing for MSK symptoms is the physical exam. For that, we take a look at inspection, palpation, range of motion, special tests, and imaging towards the end when the physical exam is not enough. Next slide, please. Going over inspection, this is when going back to the med school days, remembering that you paid over anywhere between $100,000 to $400,000 in medical education. So being able to describe to your preceptor or attending kind of what you're looking at, and also making sure you are not missing things like a very obviously broken bone, the patient is diaphoretic and sweating, they're tripoding, and it's super dangerous and you need to get an O2 sat. These are things that need to be done as you're walking into the room and talking with the patient. Next slide, please. Going into palpation, really taking a look and touching patients. I know with COVID, no one wanted to touch patients or be close to a patient, but now we should touch patients and figure out what's happening in terms of swellings, deformities, muscle wasting. Here's just a quick thing to take a look at every single joint and area of things to be concerned and worried about. Next slide, please. From there, going into range of motion. So really determining if something is normal versus abnormal. On the QR code there is Physiopedia, one of my favorite references for all things musculoskeletal related. On there, it has all the different range of motion for all the different joints in every part of the body. Next slide, please. From there, you want to do special tests because that really does help determine how to figure out whether or not something is an issue or not. There are a lot of different resources on how to do special tests. For those that are old school, there are books. On the left is a book that I feel like is one of the best ones for special tests and musculoskeletal examinations. For the opposite of books, we now have YouTube to do and see how special tests are done. In the middle, of course, is another QR code to Physiopedia that has all the special tests. Just note for special tests, specificity and sensitivity, spin in, snout out, to figure out whether or not the special test you're doing is particularly sensitive or specific. From there, and finally, when all else fails, next slide, we go into the imaging modalities. You have your things from ultrasound, X-ray, CT, MRI, PET CT. Each one has their pros and cons of different things that you want to do. Check out the radiology bootcamp if you want to learn more about different things, but each one has different things related to the MSK. And from there, we move on to geriatrics with Ryan.
Thanks, Justin. Last and not least, ending with the end part of life. So for geriatrics, this is people who are 65 and above. We're family medicine. We take care of the full spectrum. The population is aging. All of this will be very relevant to all of you. So next slide. First and foremost, the Medicare annual wellness visit. This is a specialized wellness visit that we do for patients who are 65 and above and also have Medicare insurance. Basically, it is like a glorified wellness visit where you also talk about like, what is your housing? How is your function? Do you poop and pee well? Do you live with folks? What do you do every day? And they also have like this like super long slew of questions that basically goes over like how's your mental health? How do you feel about your health? What are like um how are you connecting with people in your lives? One very important part is talking about advanced directives. And so this is a special time where you can talk about patients' goals. So we'll go to the next slide. Polypharmacy, you know, it's kind of shocking, but anytime that you see a patient who has 5 or 4 meds, that is technically polypharmacy. Why is this so important? You know, 15% of older adults report adverse drug events every 6 months, and 25% are hospitalized for med-related problems within 5 years. How can you kind of look at someone's med list and be like, this is something that we could optimize? I would kind of start with the Beers criteria. You can just Google this or find it anywhere online. And it really talks about like what are medications that are higher risk for aging populations and what are the possible drug-drug interactions between different medicines. And then, you know, I feel like in medical school they do a pretty good job of talking about like this is polypharmacy, this is how you look at it, but then what do you do? And oftentimes as family medicine, we end up like collecting patients who come back to see their PCP and suddenly they have like 5,000 new meds. And so to deprescribe we won't go into the details of how to do it, but these are 2 resources that I feel like are pretty good for taking that first step. Hearing loss. So this is something that I feel like is really not taught that much in med school, but you know, a lot of older people have hearing loss. And so oftentimes you'll talk to people in clinic and they'll be like, oh, I can hear just fine. It's just that people are mumbling or it's too noisy in restaurants these days. And so these are kind of like examples of things that people may say to you as like in relation to their hearing without saying overtly like, yes, my hearing is bad or like, yes, I have hearing loss. And so just kind of like be cognizant of how people are phrasing things and put up your signal for like, maybe we should talk about hearing loss and testing. If these things are true for patients, I would recommend sending them to both ENT and audiology for formal testing. And then, you know, what do we do about that? So I think like even though oftentimes we are not the people to prescribe hearing aids, it's important to know what is available because a lot of people want hearing aids and they don't really know much about them. So there's the classic hearing aid, which is the one that's like a little doodad that they put in the ear. There's a Baha, which is a bone anchored hearing aid, which is different from a cochlear implant, which has an implanted device that then stimulates the auditory nerve. And then there are actually a huge slew of over-the-counter ones, which are technically like more affordable, but actually like none of the audiologists know how to use the apps that go with them. So oftentimes there's like a higher barrier for patients to figure out how to use them. And then if you click, they're just like sample hearing aids. So you know, these are just based on patient preference. Some people like really powerful ones so that they can hear better. Other people are like, oh, I don't want to make people know that I have hearing issues. So there are like way more discreet ones. Next slide. Okay, driving is a huge thing for older adults, you know, as like the baby boomers are suddenly like 80 years old, we don't want like 60% of the drivers to be not able to see, have cognition issues, you know. So this is something that we all should be talking with our patients about. And it can be kind of triggering, you know, like taking away someone's ability to drive significantly impacts their freedom in life. And so this is like a conversation that you should take very delicately with patients. And actually, it's really more of an objective assessment. I feel like there is this connotation of older drivers being less safe, but actually, it's younger adults that are the highest risk for driving incidents, and hence why insurance companies charge you more when you're just like 16 years old for car insurance. Um, but basically, what you want to do is just be like, so how is driving for you these days? And if they're like, well, it's actually kind of harder, then you can be like, okay, well, in general, what do you think about driving? How's your vision, your cognition, and your motor and sensory stuff? Because, like, if you cannot literally turn your head all the way around to see behind your car, then it may not be safe for somebody to be driving. The treatments for this are quite limited. There are technically driving rehab specialists, but Medicare does not cover this. And so it's pretty sad. Patients often are kind of left with this feeling of like, well, I guess we just take away my license, which is sad. And then in terms of reporting, actually, it's an ethical obligation as somebody who is caring for the community to say like, actually, you should not be driving anymore. In most states, it is not required, but I listed a few here. So California, Delaware, Nevada, New Jersey, Oregon, and Pennsylvania are a few states where if you're practicing there, it's actually mandatory that you report that somebody should not be driving anymore. And of all of the states, actually Washington, D.C., which is not even a state, is the only place that requires a retest at 75. So last but not least, we're going to talk about difficult conversations. And so I mentioned advanced directives before. These are the things that we do to make sure that patients' wishes are adhered to. And so a living will constitutes like a broad spectrum of documents. So these are all things that we refer to when somebody is no longer able to speak for themselves. And so, for example, DNR DNI, that's do not resuscitate, do not intubate. There's the PULSE, which is physician or medical orders for life-sustaining treatment. That often includes the DNR DNI at the very top, but then it kind of goes into more granular stuff of like, well, if you're not intubated, but you still can't talk, like, do you want us to give you nutrition via a tube or injections, or do you want antibiotics and etc.? Organ donation actually is a form of a living will, and brain donation is something that you could opt into. This is purely for science reasons. Obviously, we're not transplanting brains at this time. For other advanced directives, there is the DPOA, which is a durable power of attorney. Healthcare specifically, there is a DPOA for finances. This is not the same thing. And so this is somebody that like, hey, if you are incapacitated, like this is somebody who is not your next of kin that you have designated as your spokesperson. Next slide. Code status, this is something that all of you will need to know about because you will be doing some sort of inpatient medicine in some capacity, and you will need to talk to them about what they want if an emergency occurs. And so code status, this is basically like, what do we do if you die, right? If your heart stops beating, if you are not breathing, you are technically dead. And so it tells us like if you're full code, then we will do everything in our power to bring you back to life. That means CPR, intubation, and sometimes other things, like the whole ACLS workup with epi and all that other stuff. But one thing to distinguish that's really important is like you can technically do isolated DNR. So like, oh, I want chest compressions, but I don't want a breathing tube. Or like, actually, I don't want people to pound on my chest, but like if I just need oxygen and a machine to help me breathe, then that's fine. But like if you truly are in a situation where your heart stopped and you stop breathing, it's very, very rare for anybody to be successfully resuscitated if you only do one or the other. And so that's something to kind of flesh out a little deeper with people when they opt for this kind of halfway point. And then DNR DNI is to say, like, look, if I'm found dead, I do not want to be resuscitated. And sometimes that may be a better option for people. Next slide. Of course, all of these conversations are super touchy and sensitive. And so these are just a few different frameworks to work off of to guide your conversation. I'm sure many of you have heard of spikes before in medical school. And this is just an acronym, which I feel like is kind of hard to remember, but I'll go over it right now. So setting up the interview, assessing the patient's perception, obtaining the patient's invitation, giving knowledge, looking at emotions and empathy, and then strategy and summary. These are all things that you can read on your own time. And if you click, there's a screenshot of like, if you Googled spikes, it will come up with this article basically. If you want to go ahead and go to the next part. So yeah, this is like, if you just Google spikes delivering bad news, it'll come up with like this kind of article by Bale et al. And it'll go over all the different steps. Next slide. The one that I kind of have been gravitating more towards recently is the Ariadne Labs Serious Illness Conversation Guide. And this is like a consortium, like a research consortium that has been co-founded by Atul Gawande. And so it's not to say that like this is way catchier or more intuitive than Spikes. I just think that the infographic is prettier and it's easier to print off the one page. So if you click again, it just looks nicer, and it doesn't look like a paper. And so you can just like print this, you can put it on your wall, you can put it in your journal, and it helps like kind of go over like how to talk about all of these topics. But yeah, I think that's everything. This is a slide kind of summarizing a couple of the links. I recognize that like a lot of the links are actually embedded within the individual slides. This is like a partial summation of those things. But yeah, it's 3 o'clock. Thanks for being here all the way till now, y'all. Good job. I think this is time for questions. If people have them, I'll pass it back to Tori.
Yes, this is a perfect time for questions. I will be reading some closing remarks just to wrap everything up. But for our audience members, please feel free to continue adding your questions into the chat box, or you can unmute in just a moment after this. But I want to just give a heartfelt thank you to all of you for attending today's Family Medicine Bootcamp. I hope you enjoyed and learned something helpful or new that you can take into your future practice. I want to give also a big thank you to our wonderful speakers. They have graciously shared their email addresses on the screen here. If you have any further questions and would like to reach out to them individually. The session recording will be uploaded to the APAMSA national YouTube page. And if you would like a copy of the high yield speaker slides, please fill out the feedback form that we will add to the chat. And this basically concludes the 2024 Bootcamp series, which is sad, but really exciting. Thank you to all of our alumni, residents, fellows, and attendings who made this possible. Also, please follow us on apamsa.org website and our various social media platforms to stay up to date and involved with all of our APAMSA events. Thank you again for all of your participation today, and we hope you enjoy. So yeah, we can continue with the questions for as long as our speakers would like to, and then we will conclude.
Yay, we did it.
Yay!
Yay.
I just finished my family medicine rotation, so this is like a really nice recap of everything, but I feel like you all touched on really important concepts that I feel like maybe not everyone has heard of, like trauma-informed care, gender affirming care, and like all like the nuances of abortion medicine as well. So thank you for like such a comprehensive session for all of our attendees. Really appreciate it.
Yeah, I feel like family medicine is so broad that like basically anything could fall into family. And a lot of the skills that we prioritize end up being social in nature. So thinking about people's well-being in the context of their own bodies and how do we talk about them is something that a lot of us cherish and continually work on improving.
Wow, that was such a great speech, Ryan.
Thanks. I'm running as VP for Justin Chin when he's running for president this fall, 2024, with all of those zingers that you were giving.
No, we just have to keep it real. But yeah, I think my focus is always on keeping folks out of the hospital, but of course, family medicine is also in the hospital as well. So I think that's a good reminder that for folks in family medicine that choose to do hospital-based medicine, that our little boot camp was really focused on the outpatient side because that's where my heart lies. I don't think any true healing happens in the hospital. It's always reactive. So outside of
Amen.
the hospital, outside of the hospital is when true medicine and taking care of patients really happens. If I kept them out of the hospital, I've done my job as an outpatient family medicine doctor.
True. But I do feel like there is something really special about being a family medicine doctor in the inpatient setting in terms of like the advocacy that you can do for your patients. I'm just saying there's a lot of disappointing things about the healthcare system that happens in the hospital, and to be there as a family doctor and also have that continuity in the outpatient inpatient setting has been something very special. I also want to mention that like another like semi big field in family medicine is lactational medicine, and we didn't have any like opportunity to talk about that. It's something that's very interesting and important. I think it's like intuitively like tied into like reproductive justice as well. Like how do we empower like humans who have children to feed um their kids with their bodies and providing them that support, and we didn't get to talk about that at all, but something that I'm very passionate about as well, and also like the intersection of that with like gender care as well. So yeah, there's a lot of like I think that family medicine is probably like one of the best kept secrets in medicine because you can do so much, but you can also be very specialized as well. But the beauty of it is doing a lot.
Yeah, we didn't hit any of the big family medicine subspecialties, including sleep medicine, sports medicine. It's just the sky's the limit for so many things. So to be continued as this goes on.
Totally. And yeah, Tori, let us know how we'll like receive the feedback form responses as we sort of like modify this for next year. Yeah, we definitely I think we did a really good job trying to cover like things that made people feel like they got a lot of takeaways, but also like things that are like very like special in our field that I feel like don't get highlighted a lot. So great job, everyone. Y'all are so smart.
Yes, great job. Great timing. That was perfect as well. I didn't expect that. So that was amazing. I will follow up with Elise. I think she, in combination with our communications branch, will like compile all the feedback in like a really nice, like nicely presented document for each of you individually. And I think if there aren't any other questions coming in right now, I might just end the call, and the recording will automatically be uploaded to the cloud, and that will be uploaded to YouTube in like, I believe like a week or 1 to 2 weeks. But yeah, I appreciate you all being here, like volunteering your time. We appreciate you all so, so, so much. I hope you have a great rest of your weekend.
Thank you all. The process of this was also really organized and smooth. So thank you so much to you guys for coordinating. Really, really good job.
Thank you. Bye,
Thanks,
everyone.
everyone. Have a good rest of your night.